Fine. Well, I'm going to start talking today about acute liver failure. Hopefully, this stuff here is relevant for everyone. Hopefully, not going to go on too long. But yeah, essentially, I have worked recently in Birmingham, which is why I kind of chose this topic amongst about 30 that Zoe sent me one. So yeah, we'll go through this. Most of it is sort of focused either towards the FRCA or things that are relevant to the FRCA or FICM, but hopefully there's stuff there. There's some use. So what is acute liver failure? Well, obviously it's acute. That's the first thing. And also it's in an otherwise healthy liver. So that's what differentiates it from acute on chronic liver impairment. So it's a previously healthy liver. And it's essentially defined as in jaundice, coagulopathy, encephalopathy, and is within, essentially is performing within 28 weeks. So INR greater than 1.5 is what defines the coagulopathy, as we said, otherwise healthy liver, and then it's subclassified into the onset from jaundice to development of encephalopathy. So 7 days is hyperacute liver failure, 7 to 28 days subacute is acute, and then subacute is after 28 days up to 12 weeks. Okay, so that's how we define it. Okay, but actually a lot of the things can cause or degree of time frame. So drugs can cause hyperacute to subacute. So sometimes in the FRCA, physiology questions can move away from the heart and lungs. The liver has a massive amount of functions, so it's important to classify them for the exam and have a classification in your mind. There are several, and there are, well, you can classically do them into sort of 7 different functions, from metabolic, nutritional. There's actually up to 10, 20 different ways, 10, 20 different subheadings that you can classify into. But it is a sort of primary Bible question. So extensive functions of the liver. So we talk about sort of metabolic, synthetic, but actually it's still more even storage. And actually the proteins produced have extensive effects throughout the body, so coagulation factor production. And this really explains the sort of wide clinical presentation you get both in acute liver failure and chronic liver failure. I'm not going to go through all of those things, but things like thrombopoietin production, hence why platelets don't work, and also those coagulation factors. But also note that protein C and protein S are anticoagulant factors, which is why sometimes the coagulation tests in the lab are not always reflective of the actual coagulation that the patient is experiencing. Storage of glycogen and gluconeogenesis explain why in acute liver failure you can get low glucose. So presentation of liver failure. So it is rare. So less than 10 cases per million person year, which is essentially the number of cases per year over essentially then the total population and the years of exposure. So it's a strange way of presenting it, but it is actually quite rare, which is why we have so few sort of tertiary liver centres. They present with a range of signs and symptoms, and obviously it may be known, patient turns up and goes, I have 100 grams of paracetamol, now I regret it, to someone turning up with essentially reduced GCS and no clue. Looking at it, most often they come up with GI symptoms, so nausea, vomiting, abdominal pain, and neurological symptoms, so lethargy to sort of full-blown encephalopathy or coma. It's a low SVR state, so generally it's sort of tachycardia, acidosis, so tachypnea, to full-blown sort of looking like a septic shock picture. A recap of the grades of encephalopathy. Can anyone remember them?
Grade 1's a bit mild for 1, isn't it?
Yeah.
It goes up to 1, which is coma.
Yeah. Yeah. Generally, yeah. 1's the best, 4's the worst. Sorry, it's not translated very well when I downloaded it. Sorry about that. But yeah, so grades 1 to 4. Sort of 4 is essentially coma and decreasing state as we go. Grades 3 and 4 will tend to be when we start getting referrals for ITU. Grade 2 occasionally if they're really difficult to manage or if they've got other things going on. So causes, infective and non-infective. And I'm sure you probably remember from medical school, non-infective is what we see most of, and most notably is paracetamol overdose. Other drugs obviously can cause acute liver failure. Viral hepatitis is the most common outside of the developed world, particularly B and E. E is particularly prevalent in India, I believe. E is particularly prevalent on the Indian subcontinent. There is reasonable numbers of hepatitis A in Mediterranean countries, and hepatitis A is definitely sort of notifiable disease in this country. I did see one case of Hep A, but it's quite rare. But most of the stuff is drug induced, generally paracetamol. All right. So there are many drugs that can cause it. These are the most commonly noted, but there are more than this. Obviously, chemotherapy often causes it. Other causes, so sort of lack of blood supply or lack of oxygen, so hypoxic hepatitis, as a rebound from decompensated cardiac disease. Pregnancy is always an important one to remember, certainly for the exam setting, often slips the mind. So acute fatty liver pregnancy or HELP and preeclampsia. And then you've got some other essentially categories. You could argue whether hemophagocytic lymphohistiocytosis fits into another category, but autoimmune is quite common, as is Budd-Chiari. Wilson's disease tends to cause more of a subacute picture, and often develops over such a period of time. You could almost argue it's acute or chronic. Infective causes, everyone knows about the hepatitis. Otherwise, HSV and varicella and Epstein virus and HIV can also lead to acute liver failure as well. Okay. As I said, hepatitis A has a reasonable prevalence in Mediterranean countries, occasionally develops in this country. So pathophysiology, don't always think about pathophysiology, and I didn't really think about it until I got asked it revising for the Thickham exam and made myself feel a bit of a tip. Essentially, it's all about hepatic necrosis. So an otherwise healthy liver has an insult, the hepatic cells die, and they then produce, as well as a wide range of intracellular contents, they produce molecular patterns. So drug-associated molecular patterns or pathogen-associated molecular pathogens, and these result in widespread inflammation across the body, causing a sort of low SBR state. And that's what essentially, although we don't use SIRS anymore, gives the presentation of SIRS. Okay, that's the initial reaction. You also, following that, also get some inflammatory cytokines that actually reduce inflammation, and then the patient becomes actually immunosuppressed and a risk of sepsis. So sepsis is the leading cause of death from acute liver failure. But going through it from an exam, the exact mechanism depends on the underlying cause, and Ray's syndrome and acute fatty liver in pregnancy don't quite follow that pattern of liver cell necrosis that ends up causing essentially the sort of multi-organ shock. So either necrotic or direct damage to the hepatocytes, or also as a result of the inflammation and damage, the cells undergo programmed cell death, so apoptosis. And then you get the production of molecular patterns from either non-infectious or infectious causes. They're recognized by toll-like receptors on various different immune cells. It's predominantly from the innate immune system. Then you get pro-inflammatory mediators, and then you get the strong inflammatory response, resulting in all the extrahepatic manifestations. So that's the sort of pathophysiology of the low SBR state, the multi-organ sort of septic shock picture that you tend to get with acute liver failure. Hepatic encephalopathy has a slightly different pathogenesis, in that because the liver is damaged, various toxins are not downgraded. The most important one, as we all know, is ammonia. But that's not the only thing that's going on. As a result of the low SBR and the inflammation, there's also disruption of the blood-brain barrier. There's also increased cerebral blood flow. So there's increased delivery of these toxins. There's also, as a result of this, osmolar shifts within the patient. So usually, and most notably, hyponatremia. So all of those things together contribute to development of essentially cerebral edema, which can also lead to raised intracranial pressure. It's not completely understood. But as we said, increased cerebral blood flow, altered blood-brain barrier permeability. The ammonia causes accumulation of glutamate. That is an excitatory thing which increases oxidation, but also leads to depletion of ATP and GTP. You also get osmolar derangements, and the end result is you get cell swelling, you get brain edema, you get increased intracranial pressure. I think just because it's the most common cause, it's a good idea to just quickly revise paracetamol, the pathophysiology of paracetamol overdose toxicity. This does come up in the FRCA. So there is FRCA here, as well as SPICM. Essentially, normally, only 10% of paracetamol is broken down into the NAPQI, which I can't say, still can't say. And that is rapidly conjugated with glutathione. However, in overdose, and most of the times 80 to 90% is conjugated comfortably with glucuronide sulfate conjugates, which is excreted in the urine. Also know that so it's less than 5%, but some is still excreted unchanged in the urine. So it can also cause some direct tubular toxicity in overdose or in patients who are alcoholic, or potentially could mean they already had a degree of liver impairment or malnourished will have reduced stores. And that is what N-acetyl cysteine replaces. So it's essentially a saturatable system, and that is why the treatment with N-acetyl cysteine is to replenish those stores so it can be conjugated to a non-toxic metabolite. So investigations for liver failure, you can have whatever you like, you've just kind of got to justify it. But essentially, if you actually look at it, it's basically everything under hepatology, including Clark. Essentially. So remembering the point of care tests, so TEG is probably more useful in dealing with coagulopathy than the lab tests. Blood gas will give you glucose and lactate. ECG, if there's some uncertainty as to why the liver's failing, or if they present with epigastric pain. Hematology, again, nothing particularly exciting there. Group and save because you will be giving blood at some point, if not immediately. Making sure we do fibrinogen levels. Pretty much everything in biochemistry. Anyone who sort of presents with an overdose or unconscious or reduced conscious level should really consider doing a paracetamol salicylate level. All of these things can potentially be affected by acute liver failure or point to acute liver failure, or an alternative diagnosis. And tox screen, particularly important to do. In terms of things like Wilson's disease or autoimmune hepatitis, these would be recommended immunological tests. Virology, even if you're not expecting or suspecting a cause, it would be important to have a HIV status and look for these viruses if the patient's informed of hepatic failure, as these will need to be done before considering transplant. In terms of imaging, liver ultrasound is first choice. Triple phase CT abdo or MRI of the liver can also be used, and a CT head, and asking the radiologist to comment on cerebral edema because they don't always look for it. So management is probably, I think, slightly more interesting. The management of acute liver failure is largely supportive. Okay, it involves neuroprotection, and it should be, although there's well-established King College criteria for transplant, acute liver failure should be discussed with the transplant unit before they meet those thresholds. Transfer to liver unit has been shown to improve outcomes, even excluding the transplant itself, even when the confounder of the transplant is taken out. So having the increased expertise there helps. They may have access to other things, so the use of synthetic livers or the use of plex is also something that may usually be undertaken in a specialist centre or a transplant centre. So whenever you're asked in the FICM or the FRCA how you manage a patient with certain things, you say in a very contrite way, A to E, treating abnormalities as you go with a specific focus, but there's also a practical answer. So the exam answer, A to E. Specific treatment, so NAC is pretty much given for everything, regardless of whether it's paracetamol or not. ECLS, so some extracorporeal support. So King's have written about using ECMO for patients. There's also been various trials about synthetic livers, which we'll touch on briefly, and transplant. Practically, it's generally multi-organ support, which we get involved with, and an early discussion with the transplant centre. And I hope this is not what I sound like, but I'm not sure how many of you actually even are old enough to recognise this reference. It's American Pie. Yeah. I watched this when I was a teenager, which probably shows how old I am. I hope I don't sound like that about them. I'll let you say it. To go through systems, we might have to intubate for various reasons. Grade 3 or grade 4 encephalopathy is the sort of standard sort of indication that everyone knows. Low threshold for transfer, depends where you're going. Control of ICP is another reason. So obviously to get best oxygenation and control of CO2. If they're going to intercepted shock, then metabolic demand will be reduced. Encouraging, essentially, the rates of ARDS are low, even though King's have written about using VV ECMO for their liver failure patients. As they're immunosuppressed, and the ventilator bundles are high risk for that. CVS and fluids, so it's a low SVR state. Normally the heart is pumping away and emptying pretty well, functioning pretty well. NORAD is the vasopressor of choice, despite the idea that there is some sort of vasoconstriction in the hepatic artery. Telepressin potentially worsens ICP. There's not a huge amount of evidence for vasopressin, but again, Birmingham are quite keen on using it. Vasopressin has been shown elsewhere to potentially reduce the number of patients that require renal replacement therapy. MAP targets, it's a bit like neuro in many ways. You target a CCP, a coronary diffusion pressure. Generally, Queens use 75 unless there was other things, other considerations. So 75 is sort of standard, which is a little bit lower than you do for your sort of neuro patients, where you'll be looking at 80 to 90. Albumin doesn't improve outcomes, but we'll throw it around. It's one of the areas we're still allowed it with acute liver failure, so use it. Don't routinely use steroids unless it's autoimmune hepatitis, because of the risk of infections. Neurological, so ICP, briefly touched on. So maintaining your CCP. Also moved away from using bolts and subdural catheters. So there used to be a trend towards using bolts, so ICP bolts to measure pressure. It's not been shown to improve outcomes, and it has a 1% risk of fatal bleeding, and sort of 2 to 8%, depending on where you look, risk of bleeding events. And considering where it's put, it's not somewhere where you want bleeding, and the patients are obviously usually coagulopathic, which we'll come on to. So intracranial pressure monitoring has gone out of fashion, essentially to do with CT, even though CT is poorly specific for seeing raised ICP. Using actual monitors haven't been shown to use any survival benefit, but with some evidence of harm. Other monitors like transjugular saturation monitoring, etc., also hasn't got any evidence behind it. It's not routinely used. Unfortunately, in many patients, pupils blowing is a fairly late sign. So generally, just aiming good neuro protection care. So CO2 4.5 to 5, sodium sort of 145 to 150, maintaining an adequate amount. The risk factors for ICH, so the more acute presentations, And as you probably have guessed, so younger people have less room to swell as per neurosurgery. If they've got renal or cardiac function, a worsening inflammatory response, and persistent ammonia above 200, probably not a shock. We've actually got better at it. So it used to be like in the 1980s, about 76% of people had raised ICH. That's now down to sort of 20% from King's sort of retrospective study from 2004 to 2008. They've said it's because of improved critical care, but I do wonder if it's also because we're admitting older patients with more room to swell. I don't know if there's been an increase. I can't find any evidence if there's been an increase in people who are older taking overdoses, getting acute liver failure. But I think, like everything, the age at which you consider someone for a transplant seems to have creeped. So I wonder if there's slightly older patients as well. As we said, declining use of ICP monitors. Nice, still recommend-ish if you've got expertise in that area. But if no one's doing it, the expertise is falling. So if they're high-risk patients, then there's still some recommendation from the European Society of Hepatology to consider ICP monitoring, but it's getting used less and less. So the expertise is getting less and less. As I said, other monitors, so near-infrared spectroscopy, jugular venous saturations, not routinely used, minimal evidence for. So the cornerstone remains neuroprotection strategies. So ventilation control. Despite the concern about sort of propofol infusion syndrome, propofol and opiate is the mainstay of sedation for these people. Try and keep ammonia less than 100. So instituting renal replacement therapy, as that will control the ammonia. So high ammonia. Essentially, back to Birmingham, anyone with grade 3 or grade 4 encephalopathy is filtered, regardless of ammonia. So, and that's pretty much, if you listen to King's, that's pretty much what they advise. So if anyone's encephalopathic enough to get onto ITU, you filter them, rather than a number. There's various degrees of hypertonic saline recipes from 2.7% up to 30%, which obviously 30% needs to be given by a central line. No use for mannitol. So seizures don't routinely use, no evidence for seizure prophylaxis, but vigilant for seizures and treating them if they are seizures. So renal, as we've discussed, ammonia is dialyzable, so you can get rid of it. In acute liver failure, up to 85% get acute renal failure anyway, or AKI. As we said on the paracetamol slide, there is some direct tubular toxicity of paracetamol. And the risk factors for AKI, as well as paracetamol, probably not a shock, but it's also older age, hypertension, infections, and is associated with a worsening of hepatic encephalopathy and outcomes. Hypoglycemia is common, and going back to neuroprotection, ideally use high concentration solutions with low volume, so 20%, 50%. The other thing is they quite often they have increased protein catabolism and energy expenditure, so they have fairly high protein diets, despite the risk of sort of ammonia accumulation or increase, but they have a low threshold filtration anyway, and you almost always give these people PPI. Coagulation. So as we said earlier, although the liver is responsible for making a lot of the coagulation factors, it's also responsible for making anticoagulant factors such as protein C, S, antithrombin. Therefore, the coagulation can actually be, the patients, even with a raised INR, can actually be pro-coagulants. The use of thromboelastography and essentially replacing coagulation factors based on that. FFP kind of more used as a, because you're not always sure exactly what factors you've got in there. Essentially, the mainstay of resuscitation was mainly platelets and cryo, and then FFP along with albumin was almost used for volume replacement. Obviously, other basics like making sure they're not hypocalcemic or acidotic helps, but these people require fairly massive transfusion. If the TEG's near normal, then tend to give VT prophylaxis, even if the platelets are like 55, and the INR's 2, they still may require VT prophylaxis. So the situations, remember, so when a study was done, showed that even with a high INR, 20% of the patients were normal and 35% were hypercoagulable. So use of TEG or RO10 to guide coagulation correction. Also, given the risk of overload and congestion, really correcting coagulation only if there's bleeding or if you're planning for surgery or invasive procedures. Again, I think all of us have, or most of us have put our lines, central lines in, fast caths in, people quite hypercoagulable. Jugular line with a nice big juicy vein, which sometimes often is, especially once they're positively pressure ventilated, then probably just go for it without platelets. And yeah, use of FFP is sort of volume expansion resus. It was sort of cryo and platelets the mainstay. We haven't quite moved on to sort of recombinant factor 7 and routine use of things like alteplase. Very excellent. Infection. So the liver produces a lot of the complement proteins. As I said earlier, you get a late anti-inflammatory response, so mediated by IL-4/10 and transformed growth factor beta, and you essentially get impaired function of the macrophage and neutrophil function. The consequences, essentially, as the sepsis, as said earlier, is leading cause of death, acute liver failure. And essentially, if they've got a significant infection, you can't transplant them. Gram-negative bacilli and gram-positive cocci most frequently isolated. Fungemia seen in 30%. I've seen some new antifungals that I didn't really know existed. So Andula fungin, isomecanoxonium as well. So they busted out some pretty novel antifungals. And it definitely felt like more than 30% have got fungal infections. Obviously, either during the acute liver failure or post-transplant, there are risk of viral reactivation. And giving out antibiotics and antifungals prophylactically doesn't have any survival benefit, but it can do anyway. It reduces sort of sepsis and hepatic encephalopathy. Unfortunately, with a lot of these things, because acute liver failure is itself rare, then you're sort of lacking quality evidence. It's hard to get high quality evidence. So specific therapies. So NAC is used for everything. So no evidence any significant harm from an acetylcysteine. So that's given across the board for all liver failures. All right. Steroids is only really used for sort of autoimmune conditions. Hepatitis, there's not a huge amount of evidence for antiretrovirals, but there's some. And then Wilson's disease, chelating agents like penicillin A. They're your sort of specific therapies. So it would depend on the underlying cause. Obviously, in PET help then delivery of the baby, delivery of fetus some way or another, is the specific therapy. Discussion with the transplant centre. So widely used is the King's criteria for actual transplant. But essentially, if anyone's significantly unwell with acute liver failure, they should be discussed with a transplant centre or advised transplant centre. Does anyone remember the King's criteria off the top of their head?
pH, pH less than 6.5.
Yeah. Despite it's like 24 hours of fluid resuscitation. It depends on whether it's paracetamol or not. But I said INR. So King's is sort of widely used worldwide, and they use this criteria. But this is sort of criteria for transplant. Generally, when you're working someone up for a transplant, they would go through a massive MDT. So they go through MDT with hepatology, the surgeons, anaesthetists, intensivists, social worker, pharmacist, transplant nurse. In acute liver failure, that's kind of more abridged, and there is the listing for super urgent transplant is generally done by hepatology and MDT in conjunction with the surgeons. Queens have this habit of recommending intubation prior to transfer. Their concern and why they say it is because they're worried that the encephalopathy will get worse in transfer. Their area covers Wales to here. We drive past so many A&Es on the way to Birmingham that I think probably not such an issue for us. But yeah, when you're coming from Bristol, when you're doing any transfer, you have to consider the roads and the length of journey. From here to Birmingham is an hour on blue lights. So, but yeah, Birmingham's advice is pretty much anyone who's been transferred to for acute liver failure should be intubated, ventilated, and they will always quite often get calls from the medics saying Birmingham recommends this. I think considering our journey compared to everyone else, I think it's necessary. I mean, tend to say the view that they'll be okay. Say thanks for the advice. And yeah, improved outcomes for patients transferred. It might have something to do with the ease of finding a hepatologist. So Plex has got some evidence for it. If you think about the sort of pathophysiology of acute liver failure, so the sort of immune response, then it probably makes sense to try and remove some of that and just put in some normal plasma. It hasn't been shown to improve outcomes pre-transplant. So it's more in patients who don't go for transplant that seem to benefit the most. And it sort of brings us on to essentially liver machines. So obviously we're well versed with dialysis machines and renal replacement therapy machines. Trying to make a liver machine has proved trickier. And essentially you've got two. You've got the non-biological and you've got the biological. So the non-biological are essentially based on renal replacement therapy, essentially. So you take out, so you can consider, so some would consider Plex and RRT. So just starting renal replacement therapy to take over some of the metabolic functions of the liver. Some would consider that sort of extracorporeal support or plasma exchange. There are some more sophisticated devices. So the most commonly used is Mars, and essentially that passes the blood, exchanges it with albumin through a filter, then does conventional renal replacement therapy on it, and then passes it through charcoal as well, to try and detoxify some of the things. There's also single pass albumin dialysis, which is like conventional. So Mars is like dialysis, whereas SPAD is more sort of continuous renal replacement therapy, but with albumin instead of the typical fluid replacement. The biological device is essentially either lab grown human or pig liver cells incorporated into the machine. So as I said, the non-biological includes renal replacement therapy and Plex. So Prometheus was the first. There's no evidence of that, and it's kind of fallen by the wayside. But then Mars and SPAD, so single path albumin dialysis, and the membrane is more selective. So yeah, Mars is like 3 circuits simultaneously. And there's been some recent evidence, I think even from 2022, I think the last evidence was in about 100 patients, which is pretty good for acute liver failure trials. And then SPAD is more of a conventional circuit, but you replace it with 4.5% albumin instead. The biologicals are bioartificial, so they aim to not only do the drug, the toxin detoxification, but they also aim to replace some liver synthetic functions as well. So the liver assist device uses human-derived cells, and then the hepat assist uses pig liver cells. There is no evidence for any of them. But it's a great idea. I mean, yeah, it's a great idea, but there's no evidence for either of those. So Mars, out of all the things, Mars and Plex have probably got about the most evidence. And renal replacement therapy is widely used, but it's used so widely. That's accepted practice. So transplant is absolutely major surgery. And so the fitness of the patient, especially one who's in multi-organ failure on ITU, has to be assessed. They bleed during the surgery, after the surgery. Their kidneys usually don't work ever again, or at least for a few weeks. It's generally now done almost like cardiac surgery, so they have a TOE at the time. Tend to wobble quite a lot. So a lot of hemodynamic instability. It's actually only 10% of the liver transplants, so most of them are for acute on chronic or chronic decompensated. So your sort of typical outpatient workup. The 5-year survival is 82% now, so it does work. The risk factors for poor outcomes, probably none of these were a surprise, but age over 60, essentially being unwell in ITU. So high vasopressor requirements, high oxygen requirements. And essentially some of the main contraindications are patient refusal. And also hepatology will take into account how many times you've overdosed, or like the patient we had with autoimmune hepatitis, if you were able to take your immunosuppressants, they will take that into account. But essentially, irreversible brain damage, not malignancy, uncontrolled sepsis. I think any sepsis is going to make a liver transplant surgeon fairly unwilling to go near you. And it does depend on the etiology. So that's the wrong way around, sorry. So it's hyperacute liver failure has a better chance of turnaround than subacute liver failure. So it was a bit late at night when I wrote that. So the faster onset, the more chance you've got of turning it around. Things like autoimmune hepatitis, Wilson's disease, your longer onset, they have less chance of getting better spontaneously. They're more likely to require transplant. Paracetamol overdoses and your hyperacute can often get better quite quickly, as quickly as they got sick, they can get better again. So they've got a better chance of turning around without transplants. Similarly, pregnancy, they've also got pregnancy-associated liver failure, they've got a better chance of turning around without transplant. Okay. And it's the hepatology MDT essentially that decides who's going to get a transplant if it's super urgent. As I said, if it's acute on chronic or it's chronic liver failure, then the MDT is wider and is a slower process. So in conclusion, it's rare, which is why we haven't got very much high quality evidence. Sort of take home messages is early discussion with transplant centre and sort of neuroprotection, good critical care, multi-organ support. Been increasing survival, and there is promise from other non-transplant modalities, most of which don't have any evidence, but Mars and Plex do have at least have a bit of evidence. Okay. Any questions? Yeah.
Citrate with replacement therapies, they tend to use like auto anticoagulation.
So yeah, they used a bit of auto anticoagulation. They didn't tend to use citrate, and they didn't use citrate across the whole floor, which was a bit odd.
Yeah. My kings do it instead.
Yeah. So no, they didn't use citrate. They used bits of heparin. Sometimes Repo, sometimes just put it through the machine and see what happens.
Yeah.
Try and error. But yeah, obviously there's risk of citrate toxicity, and I think there was a kind of hang up from that. But yeah, small doses of heparin. What they did do a bit was they had they were able to do dialysis on the unit, so they're probably also a bit more into intermittent hemodialysis as well.
Yeah.
Or a bit like our unit team, they just give a shot of tintaparin or a bit of, yeah.